The next disease here, what do we find? First of all, let's have a look here. Here we can find that there is this gross destruction of the joint space. Do you see this? That there's this gross destruction such that the bone is telescoping into the bone, right? So there is telescoping at the joint space, also called as pencil in cup. So it looks like this tapered pencil within a cup, and both of these are hallmarks of psoriatic arthritis. So remember, in psoriatic arthritis, you have a lot of destruction of bone which goes on, plus the history would be very, very typical wherein you will have associated skin changes, nail changes in the form of the erythematous plaques with those silvery scales, and oil pitting and other nail changes we find in psoriatic arthritis. In addition, if you see that there's complete destruction in advanced stages, resembles something like this, wherein all the joints are affected here, and clinically it looks like an opera glass. It looks like opera glass sign, which is a very destructive form of psoriatic arthritis, referred to as arthritis mutilans. So remember, psoriatic arthritis, a very destructive arthritis, and the most common joint to be affected here is going to be DIP. So DIP sparing in RA, but DIP getting involved most commonly in psoriatic arthritis. Going ahead, you will get the history of an older male who's been binge drinking and suddenly complains of pain of the foot at the first metatarsophalangeal joint, which is the most common one to be involved. You know that we are talking about gout, a very, very typical clinical scenario. So the radiological picture of gout, you are going to be seeing these very large erosions. Do you see these very large erosions, which are referred to as rat bite erosions, and they have these overhanging margins. You would find that the margins are overhanging from the erosions. This is referred to as the Martel G sign. So this is the Martel G sign, and one advanced CT that we can do here is a dual energy CT. So a dual energy CT can actually characterize the presence of uric acid in the joint, in the soft tissue, which is nothing but the tophi. So it can identify uric acid deposition in the subcutaneous and the joint space, and it looks something like this. So if I show you a 3D volumetric reconstruction, which is called VRT, which is volumetric reconstruction technique of the CT, wherein we produce these 3D images, you will find that there is this deposition of uric acid crystals here around the joint. Do you see these green crystals? Nothing but the depiction of uric acid crystals by a dual energy CT. So remember, dual energy CT, two applications. One is again the application of gout, wherein we can see uric acid crystals. Plus, if you have calculi, if you have renal calculi or ureteric calculi, again dual energy CT can tell us whether it's a calcium oxalate stone, or it's a uric acid stone, or it's a cysteine stone. So again, it can characterize the renal calculi further. Okay, so these are the two advantages of dual energy CT that you should remember. Going ahead to the next part here, so what do we see? We see that there is a typical history which is given here, that it looks very bad, the joint looks very destroyed, it looks very edematous, distended, but the patient tells you that I am feeling fine, I do not have so many symptoms like you are saying. So it looks bad on the X-ray, but the patient feels okay. So X-ray clinical picture, quite scary, but patient doesn't have pain. So why doesn't he have pain? That is because all his sensation is lost. So that is why this type of joint is called the neuropathic joint. This is referred to as neuropathic joint or Charcot joint. Okay, and this occurs in patients who have a neuropathy. Most commonly we see it in diabetic patients, and the area to be involved is again the foot, which will be most commonly involved. The mid-tarsal joint is something which is most commonly involved. Apart from that, other causes can be any causes of neuropathy, such as leprosy. Alright, a lot of times syringomyelia will also lead to loss of sensation in a cape-like distribution. That is the buzzword for syringomyelia. So you will have bilateral elbows, shoulders getting affected in syringomyelia. Apart from that, any neuropathy cause basically can lead to it. So looking at the X-ray, so it's described as having these 6 typical Ds. So the 6 Ds of neuropathic joint are: 1, it will be distended. That means that there will be joint effusion. Second, it will be very dense. The density is going to be increased here. So if you look carefully, First of all, can you see the distension here? This is a joint effusion, and the bones look quite sclerotic. They look whiter. So this is suggestive of increased density, plus there is this gross destruction. The bones are markedly destroyed. So you have destruction, you have a lot of debris which is there. Joint dislocation can also happen, and overall there is disorganization. So all of these bad D words which indicate that the joint is in a bad state, this tells you that it's likely a case of neuropathic Charcot joints, particularly if the patient tells you that it's not very painful. Okay, so this is neuropathic joint. Now, just to get a few one-liners out of the way which are frequently tested, what is the disease wherein you see epiphyseal enlargement? So here, remember, you have juvenile idiopathic arthritis. So in juvenile idiopathic arthritis, we see that one epiphysis will be asymmetrically enlarged. Where do you have epiphyseal dysgenesis? So this condition wherein the epiphyses are not formed is something which is seen in congenital hypothyroidism. So remember, in hypothyroidism, because of epiphyseal dysgenesis, we'll find that the baby will have short stature, right? And widened intercondylar notch. So when you find that in the femur you have the intercondylar notch which has become very, very wide, this is something which is seen in hemophilia. So there is a feature of hemophilic arthropathy. Okay, so remember this. So these are all the one-liners that I want you to remember which have been asked previously. In addition, hemophilic arthropathy, also remember there is squaring of patella. Patella becomes square-like. Okay, so these are two features that we see with hemophilia. So now continuing with our discussion, we have a 30-year-old male who presented with diffuse back pain since 3 months. The pain surprisingly resolves when he works out at the gym. The spine X-ray is shown here. What is the diagnosis? So before looking at the image here, when you analyze the question, you find that there is pain which resolves when he works out, which means that it resolves with activity. So this is a very typical feature of inflammatory arthritis, right? So here, because we have back pain, we'll call it inflammatory spondyloarthritis. And remember, the prototype of inflammatory spondyloarthropathy is going to be ankylosing spondylitis. All right. Now, when we see the X-ray, we can see that here the complete spine is fused anteriorly, posteriorly as well. So we are seeing pan joint fusion. In fact, the posterior elements are also fused. So when you see this pan spinal fusion, this is something which is seen in the ankylosing spondylitis. Alright, so now let's discuss angspond. Just a quick word, DISH, as we have studied in our detailed lectures, remember diffuse idiopathic skeletal hyperostosis, you would have newborn formation along the ALL. So you will have this thick flowing ossification along the ALL, anterior longitudinal ligament, which looks like candle wax which is dripping. Alright, so that is the appearance you see in DISH. Klippel-Feil is a congenital fusion syndrome wherein the spine, the cervical spine, has a lot of fused block vertebrae. As a result, the neck is going to appear shorter. So they have a short neck, they have multiple fused vertebrae, and they have a higher hairline. Okay, so this is the triad of Klippel-Feil. And in Sprengel's deformity, which is the previous Ames question, you would find that one of the scapula is high riding, and a lot of times it can be connected to the vertebra with a omovertebral bar. Alright, so these are features of all the other options. So now let's talk about angspond. So ankylosing spondylitis, remember, the word itself tells you that there's going to be ankylosis, right? So there's going to be ankylosis, which means that fusion of joints is going to happen throughout the body, and you're going to have spine inflammation, right? So spondylitis tells you that it's an inflammatory arthritis. Now, when I asked you which is the most sensitive investigation or investigation of choice, so before this ankylosis happens or before this spondylitis happens, remember the earliest feature that can be seen is sacroiliitis. So remember, the first manifestation of angspond is going to be sacroiliitis, wherein there is inflammation at the sacroiliac joints, and this is manifested as bone marrow edema. So again, when we go back to our thumb rules, remember bone marrow edema, the diagnosis is made on MRI. The diagnosis, the investigation of choice for bone marrow edema is MRI, particularly the stir sequence. So the stir sequence actually means a fat suppressed sequence. Alright, so this is how we are going to be diagnosing sacroiliitis. Now, eventually, there's going to be fusion which happens, right? So there's going to be fusion and we'll see that the joints are fused. So in the end stage, we'll pick up ankylosis of the sacroiliac joints. Once the disease progresses to the spine from the sacroiliac joints, we're going to start seeing the inflammatory changes in the spine. So in the spine, remember the first sign, the earliest lesion you're going to see is near the end plates. Can you see these end plates here, the corners? So these corners are starting to appear sclerosing. Alright, so they are starting to show this whitening, which is called sclerosis. So this is also called as the shiny corner sign. So this is referred to as shiny corner sign, or some people also call this the Romanus lesion. So this actually represents the inflammation which is happening here at the attachment of the annular fibers. Alright, so at the attachment of the annular fibers, you have this inflammation, and remember this, we have discussed this. This is called as enthesopathy, and this is again a very important feature of Angst-Bond, wherein at all the ligaments and tendinous attachment sites you have inflammation. Okay, so this is called enthesopathy or enthesitis, right? And this is something which is a feature of ankylosing spondylitis, and one of that we are seeing here. Slowly as a reaction to this inflammation, we are going to have vertical syndesmophytes. So this is again going to be new bones which are going to be formed. Can you see? Connecting the intervertebral disc, we are going to have these vertical syndesmophytes which will cause a complete fusion of the spine, and eventually all the ligaments will also ossify. So as a result, you will see that all the joints, anteriorly, posteriorly, everything is fused. The posterior joints are also fused at the level of facet joints, and you are seeing this calcification of the supraspinous interspinous ligaments, giving rise to all of these name signs. So you see this tram track appearance, wherein everywhere on an AP view, you are seeing this fusion, tram track, also called as the dagger sign because of the central ossification, and because it is completely fused like a bamboo, it's also called as a bamboo spine. Going ahead, so now as we discussed, when we find in contrast, when we find this sort of a flowing ossification, IV disc is normal, all the other joints are normal. So when you find this new bone formation along the anterior longitudinal ligament in an older patient, here your prototype patient of Angst-Bond is going to be a younger male who's coming to you with chronic back pain, whereas here it's going to be an elderly male, and this diagnosis is going to be DISH, which stands for diffuse idiopathic skeletal hyperostosis, right? So this is going to be diffuse idiopathic skeletal hyperostosis. And just to contrast it, in the cervical spine with Angst-Bond, based on a previous Ames question, we'll have that there is this complete fusion of the spine, right? So remember, here you have ALL flowing ossification, this pan joint fusion, young person, this is Angst-Bond, alright? So this is ankylosing spondylitis. Going ahead to our discussion, so what do we find here? Which is the ligament which is ossified? So I'm showing you a CT, and here can you see that the ligament which runs here at the posterior vertebral bodies is ossified, which is the PLL. So we are seeing the ossification of posterior longitudinal ligament, and this condition is called OPLL, ossification of posterior longitudinal ligament, also called as Chapman's disease. So this is also referred to as Chapman's disease. Going ahead, what do we see here? So in this case, you can find that the bone's density is diffusely increased, referred to as sclerosis. So everywhere in the body, you would find that the density of the bones is increased. Plus, this is the hallmark wherein the ligament which is connecting, which is a syndesmophyte connecting the radius and ulna in the middle part, this is ossified, right? So the interosseous ligament getting calcified, you can also have associated dental changes. So all of these are features which suggest fluorosis, right? So this is a finding of fluorosis. This is the hallmark which you have to remember associated with fluorosis, which is interosseous ligament calcification. Now talking about metabolic bone diseases group of disorders. So the first disease wherein we are finding the pathognomic feature here. So what do we have? So here you can notice that the second and third proximal and the distal phalanges can you see here? Predominantly in the radial aspect. Near the thumb, the radial aspect, you are finding that there are these resorptions. Can you see this? It looks eaten up, right? So these are the subperiosteal resorptions that you are finding on the radial aspect. This is the pathognomic feature of which disease? This is the pathognomic feature of hyperparathyroidism, remember. So this is the hallmark where you have these second and third fingers, proximal middle phalanges, radial aspect, resorption, eating up of the bone, the high parathyroid levels causing resorption. In the skull, what is the kind of appearance we are going to see? So this is called as the salt and pepper skull appearance, wherein you would find that there are these very tiny resorptions. Do you see that there are these various areas of bony resorption throughout the skull? So this is referred to as salt and pepper skull appearance. Again, what else will we find? So one more feature is the loss of lamina dura. So for that you need to know what is lamina dura. So that is this normal periodontal membrane that you are seeing. So this is the lamina dura, which is this white line. So this lucent line is the periodontal ligament. Just below it, the ossified structure that you are seeing, the white line that is marked by the arrow, is the lamina dura. So in hyperparathyroidism, even this gets resorbed. So you will find that there is no lamina dura. There is no thin white line which is seen, here. So this is called loss of lamina dura. One more feature. Going ahead, what else can we find? We can find these multifocal bony lesions. So what are these multifocal, lytic, irregular bony lesions which are scattered throughout the body in the metaphyses? So these are referred to as brown tumors. They can mimic primary bone tumors, but they're going to be multiple and associated with other findings of hyperparathyroidism, right? So these brown tumors are again basically pathologically. Why are they called brown tumors? Because there is a lot of bleeding which goes into them. They are also referred to as osteitis cystica fibrosa, right? So they form this cystic sort of cavity. There's fibrosis. There's going to be a lot of hemosiderin deposition in them because of the bleeding, which results in the name brown tumors. So this is about brown tumors. Going ahead, what about secondary hyperparathyroidism? So all of these were features that were more commonly associated with primary hyperparathyroidism, which is related to a parathyroid adenoma. In turn, when you have secondary hyperparathyroidism, which means that as a result of a chronic kidney disease, what has happened is because the kidneys are unable to produce calcium because of the 1-alpha hydroxylase enzyme being deficient, so there's going to be hypocalcemic state, plus the phosphorus levels are going to increase. Why? That is because the kidneys are unable to excrete them. So both of these again give a stimulus for hyperparathyroidism, right? It causes parathyroid secretion to get excess, and this is referred to as a secondary hyperparathyroidism state. So here the finding that you'll see in the spine, the hallmark, you'll not just see resorption. You'll see resorption, bone density getting reduced, but in addition you will find sclerosis because there is phosphate deposition as well. There's phosphate retention which gets deposited, resulting in sclerosis. So this sclerosis is the hallmark of secondary hyper-PTH. So when you have these alternating bands of sclerosis and reduced density, so sclerosis, osteopenia, resulting in these alternating white and black bands which look like rugger jersey. So this is called as rugger jersey spine, and in the knee and the wrist you will have calcification of various ligaments like the menisci. So this is called chondrocalcinosis. Remember, this is referred to as chondrocalcinosis when cartilage or menisci get calcified. So remember chondrocalcinosis with two diseases. One that we are seeing, secondary hyperparathyroidism, and the other one I want you to remember is pseudo gout. Alright, so pseudo gout is again because of calcium pyrophosphate deposition. Alright, so it's calcium pyrophosphate deposition. Again, you will see that the wrist, there is a ligament called triangular fibrocartilage. In the knee, you would find menisci getting calcified. So you would see calcification of these two ligaments. Okay, so this is about chondrocalcinosis. Looking at the next disease, what do we see? So here you can see that the skull is markedly enlarged. It's markedly enlarged. Look at this calvarium, it's thickened, and you are finding these multiple white sclerotic spots which are called as cotton wool skull. And again, you would have this typical description that the person says my head size is increasing, my head is growing in size, or he could also tell you that I am having visual loss, I am having hearing loss, because his nerves are getting compressed, cranial nerves are getting compressed, whether it's the optic nerve or the 8th cranial nerve, they're getting compressed at the foramina. So this disease is Paget's disease. So remember, Paget's disease, you have variable phases, you can have sclerotic phase, you can have lytic phase, and you can have a mixed phase. So in the sclerotic phase, you will find these white cotton wool spots, and you would find an increasing hat size, which is referred to as the Tam O'Shanter sign. Going ahead, in the lytic phase, you would find that there is this large lytic lesion which is there, right? So this is referred to as osteoporosis circumscripta, a well-defined circumscribed area of reduced bone density. Further, when we look at the long bones, you would find that there is this lysis with an advancing edge, right? So this is referred to as a blade of grass or a candle flame appearance. Alright, so a blade of grass or candle flame sign is the name that is given to this advancing lysis in the long bones. Apart from that, what are the spinal manifestations? So one, because of coexisting sclerosis as well as lysis, you would find that the vertebra looks like a picture frame, right? There is peripheral sclerosis, central osteopenia, which results in a picture frame vertebra, or you can have a diffusely sclerotic vertebra called ivory vertebra. Now, differentials of ivory vertebrae are very important. So, apart from Paget's disease, you would also find them in lymphoma, particularly Hodgkin's lymphoma, sclerotic metastasis. Most commonly, you will see them from prostate in a male, breast from a female. So, these are the common primaries that you need to know. Apart from that, in a case of treated tuberculosis, alright, healed tuberculosis, you can also have this. So, in turn, it basically tells you that there's sclerosis, there's osteoblastic activity which is going on. So, all of these will be differentials of an ivory vertebra. What would you see in a bone scan? So, a bone scan is a nuclear medicine investigation where we use technetium-99M, which is tagged with MDP, methylene diphosphonate. Okay, so this is a compound that we use, which again goes to newborn forming areas. So, it picks up newborn formation. So, again in Paget's, wherever you have newborn formation, it's gonna go producing the Mickey Mouse sign in the vertebrae, and it can produce the Abraham Lincoln sign wherein there is uptake in the mandible alone. Okay, so these are named signs with bone scan. Just to give you a quick recap, where all do we see Mickey Mouse sign? So, when you do an ultrasound of the lower limb, remember at the saphenofemoral junction where you have the GSV coming into the SFV. So, this is GSV draining into superficial femoral vein, and you also have SFA. So, three of these together make up an appearance of Mickey Mouse. Apart from that, on an antenatal ultrasound, Mickey Mouse or frog eye sign is seen with anencephaly, right? It's seen with anencephaly. On a bone scan, we have just learned it will be seen with Paget's disease. And on the brain MR, slightly lesser heard of on an axial section, when you have midbrain atrophy in a case of progressive supranuclear palsy, remember on an axial section, the deepened interpeduncular fossa basically makes the midbrain look like a Mickey Mouse. Okay, so this is one more area where we see Mickey Mouse. So this is just a quick summary for you. Going ahead, what do we have here? So, looking at the next disease, you are finding these three manifestations. So, having a look at the digits, at the phalanges, what do you find? That there is this overgrowth in the distal aspect. Do you see this overgrowth? So, this is referred to as the spade phalanx. Okay. Then, when we look at the foot X-ray, can you find this gross increase in the heel pad thickness? So, there is this grossly distended heel pad thickness. The cutoffs are variably given in different places, but you can remember more than 23 millimeters in female and more than 25 millimeters in male is defined as a cutoff for this increased heel pad. And in the skull X-ray, can you see this marked prognathism, this jaw angle being increased? And plus, look at the sella which is widened. There is this widened sella, the sinuses appear enlarged, the calvarium appears thickened. So, all of these features together point to a syndrome which is causing this soft tissue and bony overgrowth. So remember, this is seen in acromegaly. So in acromegaly, because of the increased growth hormone after growth plate fusion, you will have all of these bones, soft tissue, which are all proliferating, giving rise to these features. So these are all features of acromegaly. So looking at the next case, let's say we have a child who is presenting to us with multiple bony swellings, multiple lymph nodes, multiple skin lesions, and we have these radiological features. So in the skull, you have these lytic lesions. The typical feature is they are first geographical, they are large, and they have a beveled margin. So they have that two margins which you can see. So there is this differential destruction of the inner and outer table, which is called as the beveled margins. Apart from that, the spine is showing you what? That one of the vertebrae is completely flattened, it's completely destroyed, which is referred to as a vertebra plana. Remember, the disease that we are talking about is Langerhans cell histiocytosis. It's a multisystemic disorder which affects predominantly children, causes these bony destructive lesions, and LCH happens to be the most common cause of vertebra plana in children. Apart from that, any other lesion like Ewing sarcoma or lymphoma, leukemia, any destructive lesion can cause vertebra plana. Going to the mandible, here you have a floating teeth sign which is described again because of multiple erosions in the mandible. It appears like the teeth are floating. So all of these features describe Langerhans cell histiocytosis. Looking at the next skull appearance, what do we have? We have multiple variable sized, well defined. It looks like we have punched in the skull bone, right? So these are multiple punched out lesions, also called as raindrop appearance, seen with multiple myeloma. Alright, so this is seen with multiple myeloma. One more differential would be what? The other differential is lytic metastasis. So lytic mets, multiple myeloma, both will be the differentials for this punched out or raindrop skull appearance. What about this skull appearance here? So can you see that there is this gyriform sort of calcification that you are seeing in one side of the skull? Again, complete cerebral atrophy. So we are seeing a complete cerebral atrophy with calcification. Tram track calcification is the name given to this. This is seen with Sturge-Weber. So this is seen with Sturge-Weber, particularly when you have a port wine stain, right? So you will have a purple port wine stain. Nevus flammeus is what it is called. Most commonly, where does it affect? So remember, it affects the trigeminal nerve course, most commonly along the ophthalmic branch. So along the V1 is the most common, and in addition, the triad consists of congenital glaucoma. So the patient will come with this triad of calcification, tram track, which leads to refractory seizures with cerebral atrophy. There is port wine stain, there is congenital glaucoma. This represents Sturge-Weber syndrome or neurocutaneous syndrome. Going ahead, what do we find here? So here you can see that the trabecular markings, can you see these diffusely raised trabecular markings giving rise to heron end or true cut appearance? This is an appearance which is associated with any hemolytic anemia, right? So this is seen with cases of hemolytic anemia such as sickle cell anemia or thalassemia. So this has been asked multiple times, particularly in the FMG entrances, alright? So this diffuse heron end appearance is hemolytic anemia. So here, looking at the next X-ray, what can you find? That here in the skull is showing these diffusely increased convoluted markings, right? Multiple convoluted markings which resemble a copper beaten vessel. So this is called as copper beaten sign, and this is associated with raised intracranial pressure. Apart from that, what are the other features of raised ICP? So when they ask you earliest sign on X-ray in a child, remember, because children do not have sutures which are fused, so they will have sutural widening as a result of raised ICP. So in children, the earliest sign is going to be sutural diastasis. Whereas when we talk about adults, remember the earliest sign in adults of raised ICP is going to be the erosion of dorsum sella. So the posterior wall of the sella is going to be eroded in adults. So these are findings of raised ICP. Going ahead to the next case, so when I tell you that there is a child who has hepatosplenomegaly with pancytopenia and showing you this diffusely increased density, do you see these bones are so white? So when you see increased density and also If you look carefully, can you see that every bone has a bone within bone kind of appearance? Look at the spine. Can you see that there is a bone within the bone of the spine? So whenever we have this bone within bone or a sandwich sign, the disease to be considered is osteopetrosis. This is a congenital dysplasia. This is osteopetrosis with this clinical background. Looking at the next case in the form of an MCQ, we have a 65-year-old female presenting with low back pain. You find that the calcium phosphate PTH is all normal, ALP is normal. So whenever you consider metabolic bone disease, everything is normal. What comes to my mind? It is osteoporosis. And when we look at the X-ray, what do we see? We see all the bones. Do you see how bones should have appeared white? They are appearing diffusely decreased in density. The bones are very, very weak, and as a result, because of the body weight, they are all getting depressed. The end plates are getting compressed, resulting in this kind of an appearance that is called as codfish appearance. The codfish appearance, which is associated with osteoporosis, can also be seen with osteomalacia. Okay, which is a vitamin D deficiency in adults, but more commonly osteoporosis. So now when we talk about osteoporosis, remember the investigation of choice for osteoporosis is going to be DEXA scan. So DEXA stands for dual energy. DEXA stands for dual energy X-ray absorptimetry. Alright, so this is what is DEXA scan. Basically, it measures the bone mineral density. It measures the density in terms of gram per centimeter square. So the two common sites which are used as reference is the femur, right, the femoral neck, and the lumbar vertebrae, which are used to measure the density. So here when we measure the density, it's not given as a value, but we compare it in terms of standard deviation with two kind of population. So first we can compare it with young adults. If we compare the bone mineral density of our patient with a young adult, that reference is called a T-score. That is called a T-score. Remember, young adults wear T-shirts, so T-score. On the other hand, if I compare it with the age-matched person, so whatever is the age of my patient, if I compare the bone mineral density with a normal age-matched individual, that score is called the Z-score, right? So there are two scores in terms of which the DEXA scan can be expressed. Now, what is the WHO scoring? So the WHO scoring, remember, uses the T-score. Alright, so WHO score uses the T-score for their grading. And how does it do it? So as you can see here, from +2 till -1, it is considered normal. From -1 to -2.5, this yellow range that you are seeing, so from -1 to -2.5 standard deviations, it is defined as osteopenia, and anything where the bone mineral density is lower than 2.5, less than -2.5 standard deviation, that is called osteoporosis. Okay, so this is how the WHO scaling is defined. Alright, so this is about osteoporosis. So now looking at the next disease, we have a child who's coming to us with this widening of the joints, predominantly the wrist, ankle is going to be affected. So remember, we're talking about rickets, something again very, very frequently asked in the exams. So rickets is because of vitamin D deficiency, right? So what are we going to find? Remember, what is going to be the earliest finding is going to be increased growth plate. Alright, so you will find that growth plate is increased, or it can also be expressed as this ZPC, which stands for zone of provisional calcification. So the zone of provisional calcification could be increased. So what happens here is, because there is no vitamin D, because there is no calcium, right, what is going to happen is there is going to be a lot of unmineralized osteoid waiting at the growth plate to get calcium, and the calcium is not there. So all of this unmineralized osteoid is going to accumulate here, resulting in widened growth plate, widened zone of provisional calcification. Slowly, as this further increases, it's going to cause mass effect on the metaphysis. So can you see this metaphysis, which has become very splayed? It has given this sort of a cup here because of the splaying. So this is the finding that we'll see at the metaphysis, where it becomes splayed, it becomes cupped, and there will be this irregularity which is called fraying. So all of these are signs of rickets on an X-ray. Most of the time we'll appreciate it on the wrist or the ankle joint. Eventually, when I start to treat this, What if the patient received vitamin D? What is the first thing that we'll see radiologically? So the first thing is all of that unmineralized osteoid is now going to get calcium. So it will get deposited and you'll see this white line. So remember, the sign of healing rickets is going to be a white metaphyseal line. So this is a white metaphyseal line that you will see. Sclerosis at the metaphysis is what we'll see. It is also seen. So now remember, this white metaphyseal line is not specific just for healing rickets. It can also be seen in lead poisoning. It can also be seen in treated cases of leukemia, and it can also be seen in scurvy. So scurvy, remember, we'll see a white line. Let's talk about scurvy, but we call it. So do you see this bone? Again, we see the white line. We'll call it the Frenkel's white line. So now, common feature between scurvy and rickets, both of them are going to have bone density which is reduced because the bone is not forming properly. But here, bone is not forming properly because there is vitamin C deficiency, there is collagen which is deficient, there is osteoid which is not formed properly. What are the manifestations? So all of these signs you need to know. So 1, the epiphysis will look like a ring. It will have sharp margins called the Wimberger ring sign. You will find these metaphyseal bony projections called the Pelican spurs. You will find this loosened zone above the white line, that's called the Trummerfield zone. So all of these big names are seen with scurvy. And in addition, you can also find subperiosteal hemorrhage like you see here in this case, where there is this hemorrhage below the bones which make it very, very painful, and that is why scurvy is referred to as a pseudo paralysis state. Alright, so can you see here how there is this subperiosteal hemorrhage? So this is what makes it painful, which is called as pseudo paralysis. So this is about scurvy. Looking at this image, so identify the structure marked by the arrow. So if you look very, very closely, there is one area which is sclerotic in the center, and then there is one loosened zone which is marked by the arrow. So this loosened zone is what is called involucrum, and this central white is called sequestrum. Alright, so let's discuss these findings. What are these features? So the answer here is involucrum, but we are discussing chronic osteomyelitis X-ray feature, and this is an X-ray which has figured a lot in your exams. So the central white bone that we were seeing here, right, the central white bone, that is called the sequestrum. So remember, white, sclerotic ka S for sclerotic, S for sequestrum. Why is it white? It is the dead bone, the central dead bone which is not getting demineralized. So because it is a dead bone, there is no vascularity, so there will be no demineralization. So that is why it appears sclerotic. Apart from that, the surrounding rim that was marked, which was loosened, is called the involucrum. That's called the involucrum because it represents the granulation tissue. Now all of this pus in osteomyelitis is going to become too much, and a lot of times there's going to be this cloaca, there's going to be this defect through which the pus comes out. Okay, so this is what we will see as cloaca, and then there will be a draining sinus. So all of these are features of chronic osteomyelitis. Remember, central sclerotic sequestrum, involucrum, cloaca is the hole through which it comes out, and then you have a draining sinus. So this is all about musculoskeletal radiology. So now continuing with thoracic radiology. Looking at the first question here, all of the following form the right heart border except. Now, when we talk about thoracic radiology, you need to talk about chest X-ray, and you need to know the cardiac silhouette on a chest X-ray, right? So, what forms the right heart border, what forms the left heart border becomes very, very important. So, first let's discuss the right heart border. So, remember, so when we talk about the right heart border, remember we have three structures, which is right atrium, SVC and IVC which form it, but right ventricle doesn't contribute to the right heart border, but it forms the base of the heart. Alright, so let's discuss the heart borders. So on the right side, on a chest radiograph, which is the right heart border, we have three structures. From the top, superior vena cava, right atrium, which forms the bulk of it, and a small part is formed by IVC. Now the thing to remember here, a caveat that can be put up is ascending aorta. So ascending aorta can contribute to the right heart border, alright, in patients who are elderly. Alright, so in elderly patients there is aortic unfolding which happens because of loss of elasticity. So remember, ascending aorta can contribute to the right heart border in certain cases, but these are the main structures which will always form the right heart border. When we talk about left heart border, we have these 4 structures. So from the top you have arch of aorta, which is called as the aortic knuckle. So this is referred to as aortic knuckle. Then we have the pulmonary artery, left atrial appendage and left ventricle. Note to be made, left atrium doesn't contribute to the left heart border, alright, and the right ventricle contributes to the base, to the inferior part of the heart border, alright. So these are the chambers which contribute to the heart border when we see it on an X-ray. So now when we see it on the X-ray, can you see here how on the right side we have the superior vena cava, right atrium and a very small portion by IVC. RV is going to form the base, this inferior border of the heart on the X-ray. On the left side here you have the arch of aorta, which is the aortic knuckle. We have the pulmonary artery, the small part formed by the left atrial appendage, alright, or the left auricle, and then you have the left ventricle. So remember, LA doesn't contribute to any heart border. It's not even seen on this frontal projection because it lies posteriorly. So when asked which is the posterior most heart chamber, remember it's going to be left atrium, alright. So that is located posteriorly. So now the left heart border can also be described in terms of moguls, alright. So moguls are nothing but the bumps that you are seeing on the heart border. So the first mogul that you see at the superior most aspect is the aortic knuckle, right. It's the aortic knuckle that you see, which is formed by the arch of aorta like we learnt. Then the second mogul is going to be pulmonary artery. Then we have the left atrial appendage, and finally what forms the bulk of the left heart border? Left ventricle and not left atrium. And finally, what is the fifth mogul? So remember, anytime you have an abnormal swelling at the cardiophrenic angle, so this is any cardiophrenic angle mass which can form this swelling. So that forms the fifth bump. Usually you can have hiatal hernia which occupies this position, or you can have a pericardial cyst. So pericardial cyst can also occupy this area, alright. So going ahead, this is about the heart border. So now just a few one-liners so that we have our concepts in place. So anterior most heart chamber. What is the anterior most heart chamber? They can also ask this in a different way, saying what chamber enlargement obliterates the retrosternal space. So sternum is anteriorly, behind the sternum you have a lucent space. So what chamber, if it enlarges, will obliterate that? Again asking us what is anterior, right? Or most common chamber injured in trauma. Again something which is anteriorly located will be more commonly injured. So the answer to all of this is right ventricle. On the other hand, which is the posterior most heart chamber, if enlarged, can lead to dysphagia, can lead to hoarseness, called the Ortner syndrome, and is visualized best on a transesophageal echo, because through the posterior mediastinum we are looking at that chamber. It's left atrium, right? So left atrium is your posterior heart chamber. Remember that fact, very important. Now when we talk about cardiothoracic ratio, remember we measure the dimension of the heart, maximum diameter of the heart upon the maximum thoracic diameter, and this ratio in neonates should be less than 0.6, while in adults it should be less than 0.55. Any increase from this suggests a cardiomegaly and a further workup is needed. So now let's have a look at this X-ray. This is an X-ray which represents the sign of left atrial enlargement. This is again something which is very, very important. So what are the X-ray features of left atrial enlargement? As we know, it's a posteriorly located chamber, so it won't contribute to just a heart border bulge like other chambers would. So what it would do is, can you see here there is this additional density? So this is the left atrium, which when it grows, it will basically protrude into the right heart border, giving rise to a double right heart border sign. So this is again something that we can see where it produces this double right heart border that is visualized. Apart from that, what is this happening here? So when the left atrium enlarges, you'd also have the left auricle enlarging, right? So when the left auricle enlarges, you would have a straightening. You would have a straightening of the left heart border that can be seen. Apart from this, we'll have that the carina gets splayed. There is increase in the carinal angle. Okay, so this is again one finding that when LA grows, it will cause widening of the carina. On a lateral view, remember again the left mainstem bronchus gets lifted up, resulting in a sign which is referred to as a walking man sign. Okay, so that's also called as a walking man sign, which is used for left atrial enlargement. Alright, so now looking at the next view here, name the view that I am showing you. So here can you see how the person is assuming a lordotic sort of view such that the clavicles are lifted up. So the main aim of this position, which is called the lordotic view, is to view the apices, to view the lung apices well. So this is also referred to as an apicogram. Alright, so this is an X-ray view which is done to view the lung apex, because otherwise they will be overlapped by the clavicle. This way the clavicle gets lifted. So this is used for apex, or the middle lobes also get evaluated better. Okay. Moving on, anytime you see an opaque lobe on a chest X-ray, how do you approach? Alright, so now very important. So when you see the horizontal fissure, that is how you start your approach. So there's an opacified right upper lobe in all of these three X-rays, but all of them have a different diagnosis. So when you see the horizontal fissure is in place, that suggests that there is consolidation. When you have no fissural displacement, trachea is in the midline, this suggests consolidation. One more sign that we will see is when you have this opacity, and you will see that the bronchi are air-filled and they are visualized separately. This is called as air bronchogram sign. So this is the air bronchogram sign, which is a sign of consolidation. Again, it means that the alveoli are opacified and you are having the bronchi which is patent. When we go back, now we can see that the horizontal fissure is no longer horizontal, but it's actually bulging down. So when you see this bulging of the horizontal fissure, this is called as a bulging fissure sign, and this is seen in a special kind of consolidation, which is because of Klebsiella. So this is seen with Klebsiella pneumoniae. Because of a higher virulence, the fissure bulges down. Now, the opposite is happening. We are having that the fissure, instead of being horizontal, is pulled up. The right upper lobe is very small. It is having volume loss. The trachea is also displaced towards it. So when you have these features where there is volume loss, this is right upper lobe collapse, where the fissure is pulled up. Alright, so this is RUL collapse. And if you find that there is a central mass which is causing this collapse, that is called as a reverse S sign, and it indicates that there is a central mass which is a malignancy which is causing this right upper lobe collapse. Okay, so this is what is the reverse S sign in right upper lobe collapse. So now let's have a look at the silhouette sign. So anytime we see such opacity, so right upper lobe was quite easy to figure out which lobe it is in, but for the other lobes it becomes difficult to localize whether it's in the middle lobe or the lower lobe when we see an opacity here because of the overlap on a chest X-ray. So to localize whether it's in the middle lobe or the lower lobe, we use the silhouette sign. So silhouette sign basically means that anytime you have loss of borders, like if you see here, I cannot make out the difference between the consolidation and the hard border. So when there is this loss of border, this is a positive silhouette sign, and it indicates that the opacity is actually in the middle lobe. So when there is loss of borders with the heart, that localizes it to the middle lobe. On the other hand, when you see this, that the heart border is seen separately from the consolidation, it tells me that no, it is not in the middle lobe. Okay, so this is what is silhouette sign. And to fulfill the silhouette sign, you need two things, that the heart and the lesion are in anatomical contact, right? That is what we need. And secondly, they need to have the same density. So any soft tissue on X-ray and any fluid, remember, will have the same density. Okay, so this is the silhouette sign. So let's understand this. So whenever you have a loss of border, you see a chest radiograph and you find that there is loss of border with the right heart, that means that the consolidation is located in the right middle lobe. When you have loss of border with the left heart border, it is localized in the lingula. When it's in the right diaphragm, it means that it is in the RLL, and when it silhouettes the left diaphragm, that means it is in the left lower lobe. So just to see an example, let's look at this MCQ. So here, do you see this opacity? Now, can you make it separately from the left heart border? Not really. So we can see that this lesion, this consolidation is silhouetting the left heart border, and that is why. Where is this consolidation? It's in the lingula. So that is how we use the silhouette sign. And see how diaphragm is seen separately? That means that it's not involving the lower lobes. Alright. So can I say left heart border silhouette sign is negative? No, it is positive. Located in left lower lobe? No. Located in lingula? Yes. Location cannot be commented without CT. This is wrong. We can comment on the location based on the silhouette sign. Right. So this is how the silhouette sign works. So again, if I show you this image, can you see how the lesion is merging with the left heart border? There is a positive silhouette sign that you can see. So again, we can localize it to middle lobe, which is the lingula on the left side. And one important feature on the lateral view to localize would be that any middle lobe opacity would always overlap the heart. So it will overlap the heart shadow like this case. So that is how middle lobe opacities work. On the other hand, lower lobe opacities. Look here. Can you see how there is this opacity and the left diaphragm? This is the right diaphragm. Can you see the left diaphragm separately? No. So this lesion is silhouetting the left diaphragm. And on the lateral view, remember, we can see that it falls behind. It obliterates the spine, and this is what is referred to as the spine sign. And this is when we localize it to the lower lobe. So this is how left lower lobe collapse or consolidation would appear. And when you have this complete flat waist kind of appearance, this is referred to as a flat waist sign, which actually says that this is not a consolidation, it's a complete collapse of left lower lobe triangularly. So this is your left lower lobe collapse. Alright, going ahead, left upper lobe collapse. Remember, left upper lobe collapse is going to be very, very unique in its appearance. So far, right middle lobe, left middle lobe. Both of them will have a similar appearance wherein they silhouette the heart border and they basically overlap the heart on a lateral view. Both the lower lobe consolidation and collapse is going to basically silhouette the diaphragm and fall behind, obliterating the spine. Right upper lobe, pretty evident, but left upper lobe is the unique one wherein you would see this veil-like opacity. Do you see this anterior opacity throughout? So this is described as a veil-like opacity. When you see a frontal projection, you would see this diffuse haziness and there will be this sickle of air around the aortic knuckle. So around the aortic knuckle, we see this sickle or this crescent of air, and this sign is referred to as Luft-Sichel sign. So remember, this Luft-Sichel sign is a sign of left upper lobe collapse. So these are all the collapse signs we need to know. So now looking at the next image here, what do we see? So this is your typical very, very important sign that you see on the chest radiograph. Can you see these dilated bronchi throughout the lung field? So these are all the dilated bronchi, the cylindrical bronchi that you are seeing here. This is referred to as the tram track sign, alright. So this is referred to as the tram track sign, which is seen with bronchiectasis on the HRCT, which is the investigation of choice. So remember, investigation of choice for this condition is a high resolution CT wherein you would find that this is the air-filled bronchus. Can you see these dilated bronchi? How do I know they are dilated? So remember, the bronchus and the artery. The bronchus and the artery courses together, and you would find that the bronchus becomes dilated and the artery remains as it is. Do you see this? So that gives an appearance of a signet ring. So this is the artery which is white and this is the bronchus. So this is a high resolution CT which will focus on the lung. So the air appears black. Okay. So you will have this sort of a sign which is called as the signet ring sign. So this is the signet ring sign that you will find with bronchiectasis. Going ahead to talk about aspergillus. So remember, three types of infections of aspergillus. First, when you have an underlying cavity and you have colonization of aspergillus, it's not invading. That is called as a fungal ball. That is called as a fungal ball or an aspergilloma. How would that appear radiologically? So we would see that there is this cavity. Do you see this cavity in the upper lobe? Most commonly in our country, it's because of tuberculosis. It could be because of sarcoidosis or other causes, but most common TB. So because you have a tubercular cavity, aspergillus comes and basically colonizes it, producing this fungal ball. And this produces this crescent of air. Do you see this cavity and a fungal ball, which is the air crescent sign, or the monod or the monad sign? So this is what is called the aspergilloma or the fungal ball. Looking at the next manifestation, when you have underlying bronchiectasis because of some reason and the aspergillus creates a hypersensitivity reaction, which is usually a type 1, type 3 hypersensitivity reaction, that is called ABPA. So that is a hypersensitivity reaction. Again, the aspergillus is not invading. So this is allergic bronchopulmonary aspergillosis. How will it appear? So we will see that there are proximal bronchiectasis and you will find the white mucus impacted within it. Do you see this mucus within the bronchus and how does it look? It looks like a finger in glove. So this is the finger in glove sign that is used for ABPA, allergic bronchopulmonary aspergillosis. And on a CT, we would find that there is this high density mucus within it. So this is referred to as high attenuation mucus. So this is how ABPA will appear. Finally, if you have an immunocompromised patient, particularly a patient who has neutropenia, now the aspergillus is going to invade. It will invade into the vessels, it will invade into the bronchi, and this is called as invasive aspergillosis. And how this is gonna appear is basically gonna appear as these multiple nodules. Do you see this? So again, when we look at the MCQ, post hematopoietic stem cell transplant, so an immunocompromised patient with febrile neutropenia, this is one of the most common manifestations that you will see, and we find that there are multiple nodules, isn't it? There are multiple nodules which are having one solid center and a ground glass halo. So this is called as the halo sign, and this is how invasive aspergillus is going to appear. Alright, so this is invasive aspergillosis. So I hope you've understood these three types, very commonly confused. Alright, so this is the halo sign. Now talking about a few more infections. So if you have a history of a child who's just recovered from a viral URTI and develops a consolidation, develops a pneumonia, what is that causative organism? It's likely to be Staph aureus, right? And one typical feature of Staph aureus pneumonia is what we are seeing here, which is called as a pneumatocele. Can you see within the consolidation there's an air containing cavity? So this is called pneumatocele. So one of the important features of Staph aureus, pneumatocele. Going ahead, what do you see? So here we are seeing that there is a cavity with an air fluid level, but it's just a simple air fluid level. So remember, if you see a cavity with an air fluid level, that is indicative of abscess. But if you see that there are various contents floating in it, then it becomes water lily sign. And that basically indicates that it is a hydatid cyst, and these are all the membranes of the hydatid which are floating around. Okay, so this is how hydatid cyst will appear. Going ahead, what do we see here? So here, what do you see? You see the thumb sign, which is basically the inflamed epiglottis bulging into the airway. So thumb sign, remember, will be seen with acute epiglottitis, right? On the other hand, similar upper respiratory tract infection, when you have that the airway basically narrows like this, it forms this steeple that you see on top of churches. This is the steeple sign which is seen with croup. So this is seen with croup or laryngotracheobronchitis, which is basically associated with para-influenza virus most commonly, right? In contrast, epiglottitis, bacterial disease, whereas this is a viral illness. Okay, now talking about, so remember, two interstitial lung diseases that you want to know about. First one, you are seeing that there are these basal cysts which are stacked one over the other like a honeycomb. So this is referred to as honeycombing. Secondly, can you see these dilated bronchi? So when you see these dilated bronchi getting pulled towards the periphery, this is called as traction bronchiectasis. And what is the third part? You see that there is a lower lobe predominance, there is a peripheral basal predominance. All of these triad are seen in UIP. This is seen in UIP, which stands for usual interstitial pneumonia. So this is the usual interstitial pneumonia pattern that you see of HRCT, and this is also called as IPF by pathologists. Alright, so both of them mean the same thing, where IPF stands for idiopathic pulmonary fibrosis. When we talk about the other ILD, where you have predominant ground glass opacities. Do you see? There are ground glass opacities and there is this black rim where you have sparing. This is the sparing that you are seeing, subpleural sparing. So this is seen with NSIP. This is NSIP, which stands for non-specific interstitial pneumonitis. Alright, so out of these two, remember, it is NSIP which has a better prognosis. It has a better prognosis than UIP, affects slightly younger patients. Apart from that, if I have to look at this CT more carefully, can you see here? This is the esophagus. This is the esophagus which is dilated and filled with air. So what does this suggest? This actually suggests that there is associated motility disorder, and that strikes a bell that this is likely to be related to connective tissue disorder, which is scleroderma. So remember, interstitial lung diseases very frequently related to connective tissue disorders, and this is what we are seeing here. Okay, so this is your ILD appearance. One more interstitial lung disease that we have, this is the organizing pneumonia. So this was previously referred to as cryptogenic organizing pneumonia, but now just organizing pneumonia is the term used for it. Alright, and what you will see is these peripheral nodules which have what kind of a sign? This is referred to as a reverse halo sign, right? So this is also called as reverse halo or atoll sign, wherein what do you see? So now let's understand halo and reverse halo. So in a halo sign, what we are going to basically see is that there is central solid part and periphery is going to be ground glass, right? It's going to be hazy. The hallmark of which is what? That we already studied, which is invasive aspergillosis. On the other hand, in the reverse halo, you're going to have a central ground glass like you're seeing, and the periphery is going to be solid. Okay, so this is called as reverse halo and the prototype is organizing pneumonia. Apart from this, I also want you to remember both of these can be seen with COVID-19 pneumonia. Both of these can be seen with COVID-19 pneumonia, and one more recent advance, reverse halo sign, can also be seen with mucormycosis. So pulmonary mucormycosis can also have reverse halo sign. Alright, so these are the signs. So as you can see here, can you see this very large consolidation? And what do you see? Periphery is solid, center is ground glass. So this is a reverse halo, or also referred to as atoll sign, and some people also use the term bird nest. Do you see how this breakdown is so irregular? It looks like a bird's nest. So it is also called as the bird's nest sign, which is associated with mucormycosis. So this is how mucormycosis will appear in the lung. Moving forward, let's talk about COVID-19. So when I show you these four patterns, which of these cannot be seen in COVID-19? So here again, when we talk about COVID-19 pneumonia, you need to know typical patterns, atypical patterns, right? So now let's talk about the typical features of COVID-19. So first I want you to remember that the typical pattern that is associated with COVID-19 will be the presence of multiple peripheral based ground glass opacities and consolidations. Alright, so this is the hallmark wherein you have multiple patches of GGOs, which is ground glass opacities, and consolidations predominantly in the lower lobes. However, this is not a criteria. This is the main thing that you want to see. So look here in this image. Can you see that there are these multiple white patches along the periphery? This is how ground glass opacity appears. It's this hazy white thing, but not very white. Alright, so it is white but not as white as consolidation. So this is ground glass opacity, multiple peripheral distribution, typical COVID. When I see this, again, can you see how there are these multiple ground glass opacities scattered throughout the lung? And we can also see these vessels getting dilated, which represents the microvascular sign. So this is one sign which favors COVID-19 pneumonia. What do we see here? This is something we have just studied. What is this sign? So this is a reverse halo, right? This is a reverse halo sign. Again, both halo and reverse halo can be seen with COVID-19. But what do you see here? So here what we are seeing is this tree in bud pattern, right? Can you appreciate how there are these tree in bud tiny nodules. So this tree in bud pattern is seen with centrilobular nodules. And this is the hallmark of tuberculosis. This is the hallmark of any endobronchial spread of infection. When the infection spreads to the bronchus, this is not seen in COVID. This is not seen in COVID-19. This is atypical for COVID. Alright, so just to summarize, when we talk about COVID, we represent it as a score which is called the CORAD score. Right, so it's referred to, you all have heard of it. It is called the CORAD score, which determines the risk of suspicion. How much is my suspicion that these lung findings are COVID changes? Okay, so COVID reporting and data system, just like we have BIRADS, TIRADS, LIRADS, this is CORADS. Okay, so CORADS of 0 means the examination is not adequate. A score of 1 means that I have no risk of suspicion. It's either a normal CT or there is something completely non-infectious like a mass or emphysema. A risk of 2 indicates that the suspicion of COVID is low. There are atypical findings. So what are atypical findings? Tree in bud pattern, like we saw. Centrilobular nodule is again atypical. A single lobar consolidation, like a right upper lobe consolidation, single one, atypical. Lymph nodes, any cavity, any calcification, mass or pleural thickening, all of these are not features of COVID-19. Will give a score of 2. Then we have a score of 3 and 4 wherein we are not very sure. Alright, so findings are in between. When we go to CORAD score of 5, now the findings are going to be typical. So these are 2 categories you need to know. CORADS 2 wherein findings are atypical, CORADS 5 where the findings are typical. What are the typical findings? So you have multifocal involvement. You have a peripheral distribution. Remember, lower lobe has been removed. Although lower lobe involvement is more common, it's not always needed. Okay, so multifocal, peripheral, round, GGO or consolidation, which are ill-defined. Associated, they can have vascular thickening like we saw. They can have vascular dilatation. They can have a reverse halo sign. There could be a spider web sign. So this microvascular dilatation can be referred to as a spider web, or you could have crazy paving. So crazy paving is basically when you have ground glass opacity plus interlobular septal thickening. This is what is referred to as interlobular septal thickening. Alright, so these are typical features where you give a score of 5, and when the patient is already RT-PCR positive, you give a score of 6. So this is the CORADS grading. So just to tell you, microvascular dilatation sign or prominent vessel within this. So again in this high resolution CT, can you see this vessel getting dilated? So this is the microvascular dilatation that you are seeing, and also note the subpleural sparing. Again, remember, the CORAD scoring is given on which modality? It's only given on a high resolution CT. It's not given on X-ray. So remember, it's only given on high resolution CT of the lung. Again, what is the vacuole or the spider web sign? So within the GGOs, you will find these foci of air. You will find these air foci, which is referred to as the vacuolar sign. Okay, apart from that, we've already talked about reverse halo sign being seen. Alright, so both of these can be seen where you have nodules, multiple nodules which have ground glass opacities. And then what is the severity score? So CORADS is not a severity score, it's a suspicion score. When we want to see how much is the lung involvement and want to give a severity score, there are 2 kinds of methods. One is out of a denominator of 25, one is out of a denominator of 40, where every lung segment is given a score. More commonly in practice, we use the 25 scheme method, wherein we divide both the lungs basically into the lobes. So in the right lung, we will have the 3 lobes, right upper lobe, right middle lobe and the right lower lobe. And on the left lung, we'll have the upper lobe and the lower lobe. So each of these lobes is given a total score in the range of 0 to 5. So every lobe gets a score of 0 to 5 based on the involvement. And then we add it up. We add up the involvement to get a total score of 25. Okay, so if there is no involvement, 0. If there is less than 5% involvement of the lobe, that is 1. 5 to 25, 2. 25 to 50, 50 to 75, more than 75. So this is the kind of score we give based on the involvement of each lobe, add it up, and this is the severity score. When the total involvement is less than 8, it indicates a mild infection, 8 to 15 moderate, more than 15 severe. I want to emphasize here that this is not the score that we use for clinical triage. This is not the score we use for the management guidelines according to AIMS. Okay, so this is a prognosticating method based on CT. Yes. It is a severity index. Yes. But is it used as a basis for management decisions? No, it isn't. So remember, this is not for triage into mild, moderate, severe categories according to the AIMS management recommendations. Alright, so that is something you need to remember. Now, looking at the next image, what do you see? So bilateral hilar nodes, we are seeing this peripheral calcification called eggshell calcification. Remember the two prototypes here, it can be seen in sarcoidosis, and if you have occupational related history, it can be seen in silicosis. Very rarely in Hodgkin's lymphoma after radiotherapy, it can also show you this. So this is eggshell. Now we talk about this pattern. So this is the crazy paving pattern that we just talked about. So here you have this basal ground glass opacities, and in addition there are these lines which are interlobular septal thickening. So this is the prototype of pulmonary alveolar proteinosis. So this is a congenital disease wherein you have this surfactant deficiency. So this is pulmonary alveolar proteinosis. Apart from that, this can also be seen in a bunch of conditions including COVID-19. So it can be seen in acute phase of silicosis, a rare type wherein you have acute manifestations of silicosis. It can be seen in pulmonary hemorrhage. It can be seen in pulmonary edema. Alright, so this is the crazy paving appearance. So now when we talk about this occupation related history, you would be given the history that this person is related to some occupation like a miner or in the plumbing industry, and you find these manifestations. So here can you see that there are these multiple white plaques which give the appearance of a holly leaf. So this is the calcified pleural plaque that is associated with asbestosis. So now we are talking about the manifestations of asbestosis. You will see these calcified pleural plaques everywhere which give the name holly leaf sign. Remember, in contrast, the ginkgo leaf, frequently confused, ginkgo leaf sign will be seen with subcutaneous emphysema. Okay, so that is related to subcutaneous emphysema. When we talk about this, what do you see? You are seeing that there is a peripheral opacity and the bronchovascular bundle is getting pulled here, which is the comet tail sign that is seen with round atelectasis, that is associated with rounded atelectasis, another feature of asbestosis. In addition, there is one very important manifestation you need to remember. Before that, remember the most common manifestation would be the presence of pleural thickening, which is referred to as pleural plaques that you are seeing as holly leaf. One malignancy which is most specific. So when I ask you asbestosis related malignancy, you will ask me, are you asking most common or most specific? So when I tell you most common, remember it's going to be adenoCA lung. But when we talk about most specific, it is going to be mesothelioma. Alright, so how is mesothelioma going to appear? It's going to appear as this nodular pleural thickening. Do you see this nodular pleural thickening? This is how it will appear. So a unilateral nodular pleura with a frozen hemithorax. Normally, when we would have pleural thickening, it would cause the mediastinum to be contralaterally shifted. But here, there is no mediastinal shift, which is referred to as a frozen hemithorax. And remember, when we do a FDG PET, this is going to be avid. This is going to show uptake on PET. So these are the features of mesothelioma. Going ahead to the next image, a 45-year-old male with cough and dyspnea since 15 days, all are differentials except. So when we look at the images, you see these multiple tiny nodules which are called 1 to 3 millimeter tiny nodules shaped like millets. So this is miliary nodule. So remember, what are all the DDs? Again, on the HRCT, can you see these very tiny nodules? These are the miliary nodules which are typically seen with miliary TB. But the other differentials, it can also be seen with histoplasmosis, it can also be seen with metastasis. It represents that there is hematogenous spread, of infection, but This is not seen in COVID-19, right? COVID-19 doesn't have a hematogenous spread. So this is not seen with COVID-19 miliary nodules. It becomes a CORAD score of 2 wherein it is atypical findings. Alright. Going ahead to pleural effusion. So a few one-liners of pleural effusion which are very frequently tested. So most sensitive investigation, remember ultrasound, or if in your options you have CT, that's also one of the acceptable answers. It's very, very sensitive, but frequently because ultrasound doesn't have any radiation, it scores better. Okay. Now when I ask you most sensitive chest X-ray, it will be ipsilateral lateral decubitus. So you ask the person to lie down on that same side towards the side. So ipsilateral side down lateral decubitus. Least sensitive chest X-ray, it's going to be a supine position. So when you take an X-ray in supine, that's going to be least sensitive. And what modalities can help us distinguish a simple effusion from empyema, which is an infected effusion? Remember, ultrasound can help with this distinguishing. CECT can help with this distinguishing. Alright, so both of these can help us distinguish. So now let's have a look at the image. So this is how pleural effusion appears on a frontal projection, on a PA view, wherein what is going to happen? So the fluid is going to rise up like this. So when we have a lateral margin which is upwards, this is called as meniscus sign. Remember, the earliest feature on a PA view will be what? This angle that you see. What is this angle? This is the CP angle, which is the costophrenic angle. So this costophrenic angle will not be sharp. It will be blunted. Slowly, slowly, as effusion increases, you will have this meniscus sign, also called as Ellis's S curve. So this is how pleural effusion appears on a PA view erect film. Now, when I take a lateral view, again, do you see how the anterior and posterior angles, normally they were supposed to be like this. They are also blunted and they are flattened. So this is how it is going to appear on lateral. And when we take a lateral decubitus, we'll see the fluid gravitating down. So in order of sensitivity, this is most sensitive X-ray. After that, we have the lateral view. After that, we have the PA erect view. Alright, so this is how the X-rays are in order of sensitivity. When you talk about the most sensitive investigation, this is how ultrasound will show pleural effusion. So this is the liver, and you can see here that there is this anechoic fluid. So this black anechoic fluid accumulating at the angle and the pleural surface, this is how pleural effusion will appear. Going ahead, distinguishing effusion from empyema. So we just saw how anechoic, purely black effusion will appear. If you find that there is associated pleural thickening, alright, so there is this pleural thickening which is appreciable on the ultrasound with various septations, loculations, that is referred to as empyema. So this is how empyema will appear, and on a CCT. Remember, on a CCT, we will see that there is pleural thickening and enhancement. This is the pleural thickening and enhancement that we will see, which is referred to as the split pleura sign. So this is what is referred to as split pleura sign. Normally, we will never see the pleura, but when it is thickened, it's enhancing, that is called split pleura sign, and it indicates empyema. Going ahead to pneumothorax. So when we talk about pneumothorax, what is the most sensitive investigation? Remember, anytime you want to see air, it's going to be CT scan. So CT, most sensitive chest X-ray. It will be a expiratory view radiograph. Remember, for pneumothorax, an expiratory view radiograph is done. Normally, for all practical purposes, a chest X-ray is done in an inspiratory manner. But for pneumothorax, an expiratory view will help. Okay. So how will pneumothorax appear? It will have this visceral pleural line. It will have this line demarcating the normal lung from the air. And will there be any bronchovascular markings? No, it is this complete blackness that you are seeing without any bronchovascular markings, with the reflection of the visceral pleural line, and this is how pneumothorax appears. And when it increases in amount, what can it do? It can cause this contralateral mediastinal shift. It can also cause shock in the patient. So when the patient is in an obstructive shock, that is when we call it tension pneumothorax. So remember, tension pneumothorax is a clinical diagnosis based on the vitals of the patient and not a radiological diagnosis. Okay, so this is how tension pneumothorax will present. Now let's talk about the only two indications where we do expiratory chest X-ray so that you remember. So expiratory chest X-ray, one is done for pneumothorax and secondly it is done for foreign bodies. When you have foreign bodies which are aspirated by children, again you want to do an expiratory chest X-ray to better visualize it. So these are the two indications of doing an expiratory chest X-ray. Now, what about ultrasound? So, ultrasound can also pick up pneumothorax. Remember, in the EFAST examination that we will discuss very soon, which is an ultrasound for trauma, we do utilize ultrasound for the evaluation of pneumothorax, right, in trauma patients. So, here we can use the B mode or we can use the M mode. So, in the B mode, which is the standard mode of ultrasound, you would see presence of sliding. So, when you see that lung sliding is present, it is moving, that indicates a normal lung. When you see that the lung sliding is absent, there is no movement of the two layers of pleura, that indicates pneumothorax. When you do M mode examination and you find this, that there are lines and then there is granularity which resembles a beach, right? So these are waves and this is the beach, seashore. This is called as seashore sign. On the other hand, when you just see lines all over, that is called the barcode or the stratosphere sign, again seen in pneumothorax. Okay, so these are the signs you have to remember on ultrasound for normal lung versus pneumothorax. Okay, now what if I see air fluid level? So when you see that the CP angle is blunted, there is this level and now you have air here. So this is what is referred to as a hydropneumothorax. So remember, hydropneumothorax, when you have the blunting of CP angle, when this is the pleural space where you have this. Apart from that, as we have seen in the lung, if I see a cavity with an air fluid level, that is an abscess. If you find that there are these membranes which are floating around there, you think of water lily sign with hydatid cyst. Okay, so that is our approach with air fluid level. Now, when we talk about a few signs, continuous diaphragm sign, remember, is a sign of pneumomediastinum. So, continuous diaphragm sign seen with pneumomediastinum. So, now let's talk about all the signs of pneumomediastinum. Most of the time, pneumomediastinum can occur because of airway injury in cases of trauma, or it can also be seen with esophageal injury. Alright, so in cases of esophageal rupture, which could be Borehouse syndrome or secondary to endoscopy, we can have pneumomediastinum. So, now what is this sign here? You will see that there is this air fold which looks like a V. This is something which is very, very commonly seen when you have esophageal rupture. Alright, so this Neclerio V sign is again one sign of pneumomediastinum, particularly for esophageal injuries. Apart from that, you will have air outlining the mediastinum. So when it outlines the pericardium inferiorly, that is called the continuous diaphragm sign. You will have the thymus in children being outlined by air, which is called the Spinnaker sail sign or the angel wing sign. Alright, apart from that, you can have vessels which get outlined by air, which is called as ring around the artery, ring around the artery or ring around the bronchus sign, which is also seen with pneumomediastinum. Going ahead, when you see this kind of an appearance wherein you have this lumpy bumpy enlargement, you see these rounded structures at the bilateral hilum as well as the right paratracheum, giving rise to the garland sign, where the lymph nodes form this garland around the heart, or basically it's also referred to as the 1, 2, 3 sign. So 1, 2 and 3 group of lymph nodes, or Pawnbroker sign. All of these are suggestive of sarcoidosis. Alright, so this is sarcoidosis, and the staging that we use, chest X-ray classification scheme we use, is called the Scadding classification or the Silsback classification. So this is the Silsback or Scadding classification, wherein you have 4 stages. So in stage 1, you will have lymph nodal involvement. In stage 2, you have lymph nodes plus the lungs which are involved. In stage 3, you have predominantly lungs which are involved, and in the final stage, you just have fibrosis. So these are 4 stages which have been described for sarcoidosis: lymph nodes plus lung alone, and fibrosis. Okay, so now when we do a CT for sarcoidosis, we would see that there are these multiple nodules which are clustering. This is referred to as the galaxy sign. So remember, galaxy sign seen with sarcoidosis, and when we do a gallium scan, we would see that the parotid, lacrimal glands will take up the uptake looking like a panda. So, we see a panda sign. In the chest, we would see a lambda sign. Alright, so again the lymph nodes taking uptake giving rise to a lambda sign. Alright, so this is all about sarcoidosis that you need to know. Now, talking about this very important diagnosis here, when you have a neonate with respiratory distress and the typical buzzword is used wherein and the baby has scaphoid abdomen and you see that the chest here is consisting of these multiple lucencies. This means that the bowel loops have herniated into the thorax, and to confirm, do you see this? This is the NG tube which is also going into the thorax. So, this tells us that there is herniation of stomach bowel loops into the thorax, and this is a case of congenital diaphragmatic hernia. Alright, and we divide them into two types. So, one is the Bokdelek type. So, remember the mnemonic BPL, below poverty line. So, Bokdelek hernia will be through a posterior defect, more commonly on the left side. So, left side is more commonly involved, and this is the more common type of hernia seen in a majority of cases, like our case wherein you have the hernia happening on the left side. On the other hand, you can have the Morgagni hernia which occurs on the right side, and usually the defect will be anterior. So, this is much less commonly seen. So, these are the two types of congenital diaphragmatic hernia. Look out for these bowel loops which are going in. So, they can cause this contralateral mediastinal shift. Do you see how the heart is completely replaced on the right side? So, it leads to pulmonary hypoplasia. It leads to compression of the lung. Alright, so this is very important, congenital diaphragmatic hernia. One more lesion, when you see a nodule in the chest, a nodule in the lung which has fat, which has these stippled sort of popcorn calcification, I want you to think of a pulmonary hematoma. So, this is how a pulmonary hematoma will appear, the most common benign lesion of the lung. It was also called as a coin lesion. On the other hand, when you see a nodule which has these spiculated sort of margins, right, a spiculated sort of margins, this suggests that it's likely to be malignant, it suggests a poor prognosis. So, when they ask you evaluation of a solitary pulmonary nodule, a nodule in the lung which is less than 3 centimeters, which is not associated with anything else, it's not associated with collapse, consolidation, nothing, it is just a solitary nodule, what will be the best method to investigate? So, our main concern here is whether it's benign or malignant, right? So, the best investigation is going to be PET CT because it tells us about metabolic activity. So, if it is PET avid, likely to be malignant. If not showing uptake on PET, likely to be benign. So, PET CT is the best. If not an option, high resolution CT. Alright. What about the gold standard? So, gold standard is always going to be biopsy. So, biopsy is the gold standard of solitary pulmonary nodules. Remember, for a peripheral nodule, we would do a CT guided biopsy. So, remember here CT guided biopsy is preferred for a peripheral nodule, whereas a bronchoscopic route, a bronchoscopic biopsy would be preferred for a central nodule. Okay, so this is how biopsy is planned for lung malignancies which are suspected. Finally, when you see so many nodules in the lung, this is given the term cannonball appearance. So, multiple nodules can have multiple differentials, but the biggest differential here is metastasis, right? So, pulmonary metastasis will be the most common differential. Apart from this, you can have various things like rheumatoid arthritis, Wegener's granulomatosis, septic emboli, which can be differentials, but the most important is going to be metastasis. Alright, so with this we come to an end for thoracic respiratory